What's up, guys? This is Dr. Yazan, and welcome back to a brand new episode of Clotcast, the podcast all about blood clots and disorders of the blood. Today's episode is about blood clot prevention. What are some methods and lifestyle modifications to lower your long-term risk of thrombosis? And what are some settings and situations that increase the risk of blood clots that you could avoid or be careful about? I'm excited to share that Dr. Shirisha Avadhanula will be joining me later today in the episode to discuss obesity and chronic illnesses and their risk of thrombosis. Last episode, I discussed risk factors for thrombosis to set the ground for this one because understanding the risk factors helps us know what are the situations to watch out for and who are the individuals at higher risk of thrombosis. And this helps us better navigate the topic of prevention. I'm going to focus today's episode on primary prevention, meaning how to prevent a blood clot in someone who's never had a blood clot before, in contrast to secondary prevention, which is preventing the recurrence of a blood clot in someone who's had one before. That one is a separate topic because it also goes hand in hand with the treatment of thrombosis, and I'm going to dedicate a specific episode for that in the future. There is a lot to cover when it comes to blood clot prevention, so I'm going to structure today's episode in a way that will make this easier to follow, and you can use the timestamps below to navigate or fast forward to a section of this episode that is more relevant to you. I will first discuss specific settings and triggers for blood clots, such as surgery, hospitalization, pregnancy, and so on. And then general lifestyle measures that apply to everybody as a means to lower your long-term risk of thrombosis, followed by the specific individuals who have a higher risk of thrombosis, either due to family history, a genetic mutation, or due to chronic illnesses. So beginning with the specific triggers for thrombosis. I mentioned in the last episode that surgery and hospitalization are the most common causes of provoked blood clots. So if you are a patient who is planning to undergo a surgery or is being hospitalized for whatever reason, it's important to watch out for this complication. So let's begin with surgery. Different surgeries are associated with a different risk of thrombosis, and there's different ways to objectively predict that. We often use, probably the most commonly used tool is the Caprini score, and in general it incorporates different factors such as the duration of being under general anesthesia, so anything more than half an hour or 45 minutes in the score is considered a major risk factor, as well as orthopedic surgery. Orthopedic surgery is a major risk factor for blood clots, particularly so if it's associated with a period of immobility. So whenever someone is being planned for surgery, typically there's a pre-surgical evaluation. Your doctors and the anesthetist will meet and ask you about your risk factors and family history and medications and so forth. And so if you are going to undergo a surgery that is associated with a high risk of thrombosis, or if you as an individual patient have a higher risk either due to family history or chronic illnesses, then this is factored into your surgeon's evaluation. And it's something to also inquire about. You could always ask your doctors, hey, I'm worried about my risk of a clot afterwards. What is my predicted risk and what are ways that I can lower that risk? And this is variable based on the individual patient and based on the type of procedure. This could be something as simple as general measures like ambulation and staying hydrated, compression stockings sometimes, or sometimes it requires medications, blood thinners, to prevent blood clots in high-risk situations, high risk for developing thrombosis. As always, it's very important to know and recognize the symptoms of blood clots, whether venous blood clots, deep vein, pulmonary embolism, or arterial blood clots, including heart attacks and strokes, which I cover in more detail in episode 1 of Clotcast. Seems like I'm having a stroke now. All right, moving on to hospitalization. Being hospitalized is a major risk factor for developing blood clots. And as physicians who take care of patients in the hospital, we have to take into account their individual risk of developing a blood clot, as well as things that would increase the risk during or after that hospitalization, such as immobility, the type and severity of illness, the duration of hospitalization, and so on. In our day-to-day evaluation of patients in the hospital, there's a checklist of things that we're always keeping very close monitor of. That includes your vital signs, your medications, fluids, electrolytes, blood work, nutrition, and DVT prophylaxis, or the prevention of blood clots. And the way we determine the best method to prevent blood clots depends on different risk factors. So what are the risk factors of the patient and the current setting, the illness as a risk factor for thrombosis, as well as the bleeding risk factors. Because in most patients, the way we prevent blood clots in the hospital is with blood thinners. So these are typically injections that we give to prevent blood clots unless there's a contraindication to do so, such as increased bleeding risk. In other patients who are at a lower risk of blood clots, we use sequential or gradiated compression stockings. So these are compression stockings that they help maintain the blood flow in the lower extremities, and by doing so, reduce the risk of venous stasis and thus thrombosis. And in general, if you're being treated in a good hospital by a good team of doctors, they're going to pay close attention to this and to you as a patient with your individual risk factors to make sure that they lower your risk of thrombosis as much as possible. Also, never hesitate to ask questions if you're particularly worried about the risk of thrombosis or maybe have risk factors or family history. Do feel encouraged to ask your team, hey, what are we doing to lower my risk of thrombosis while I'm in the hospital? How are we preventing a blood clot? All right, moving on to the next risk factor, which is immobility. That's another common risk factor for thrombosis. Whenever the blood flow is stagnant or turbulent in our vessels, this may increase the risk of blood clots. So in our day-to-day life, this can happen due to several reasons, either having a sedentary lifestyle or going overseas on a flight that's more than 5 or 6 hours, or on a road trip, or maybe having a cast for some sort of orthopedic injury or surgery. These are all reasons that would increase the risk of blood clots. This happens because due to the effect of gravity, there's blood pooling towards our lower extremities, and we're not moving in that position, especially if you're on a plane. So it's important to take necessary measures to try to lower the risk as much as possible. So when you're on a flight, it's important to make sure that you try to move your legs as much as possible or whenever possible. So you could do that by doing simple calf exercises, either just moving them around, ankle extension or flexion, or simply getting up from your seat. Go to the bathroom, stand up for a little bit, do a little walk every now and then. And same thing with going on a road trip. Do take breaks, park the car, get out of the car, and go to a gas station or something. And when it comes to day-to-day life, especially if you're in a office desk job type setting and you're not moving, that's also something that could increase the risk of venous thrombosis. Anything really that will lead to blood pooling down due to the effect of gravity and venous stasis, so the blood is not flowing properly for prolonged periods of time, is that risk factor for thrombosis. So make sure you're paying attention to that in your everyday life, because with time, that risk would build up. The other thing I want to comment on briefly is pregnancy. Pregnancy, as I mentioned in the previous episode, is another risk factor for thrombosis. This can occur during the pregnancy or even in the postpartum setting up to 6 weeks or so. Pregnancy increases the risk of blood clots because of the effects of estrogen. High levels of estrogen have a procoagulant effect, meaning they increase the production of or activate our clotting proteins, our coagulation factors, and that can lead to blood clots. And similarly, estrogen-containing treatments would have a similar effect, such as hormonal therapy or oral contraceptives. And this is particularly concerning in those who have risk factors for blood clots, either some sort of hereditary mutation or family history or other chronic conditions. So before starting these things, it's important to talk to your doctor and address any potential risk factors that you may have that would make you more likely to clot as a result of these treatments. And it's important during pregnancy, in addition to following up with your obstetrician, to also stay active. Stay active, get some moderate level of exercise. Compression stockings are helpful in certain situations, and staying hydrated and maintaining a healthy weight. All right, the things I just covered are very specific settings or situations that could provoke blood clots. But now I want to move on to general lifestyle measures that apply to everybody. The best ways to lower your long term risk of thrombosis include number one, maintaining a healthy weight and diet. Being overweight is a major risk factor for thrombosis. In fact, a BMI of above 30 increases the risk 2 to 3 fold. And that number further increases with every 5 points in the BMI by 20 to 30%. So, this is a major risk factor, and it's important to maintain a healthy weight and healthy diet. And then exercise. With exercise, that helps us, first of all, maintain our blood flow, our heart rate, metabolism, and this is good not just for your overall health, but also in preventing or lowering the risk of thrombosis. Next, do not smoke. You already know this, smoking is terrible, and yet another doctor is telling you the same thing. But it's very important, not just because smoking causes cancer, and not just lung cancer, it's associated with a higher risk of almost every solid tumor, as well as blood cancers. It causes COPD, heart attacks, and strokes, and it also damages the endothelium, the inner lining of blood vessels, which is a major risk factor for thrombosis. So smoking is associated with an increased risk of both venous and arterial blood clots. And this is a major way to make sure you don't increase your long-term risk of thrombosis is by simply not smoking. And lastly, it's always important to stay active, to stay hydrated, and to also follow up with a primary care doctor at least once a year annually, because a primary care physician would evaluate you for conditions that need to be treated, such as hypertension, high blood pressure, or diabetes, or dyslipidemia, or high cholesterol, or other things, hypothyroidism, low thyroid levels, polycystic ovarian syndrome, and so on. All of these things increase the risk of thrombosis, and it's important to address them. Not just they increase the risk of thrombosis, but these are conditions that lead to various complications with time, and they would need to be treated. There's many reasons that put individuals at a higher risk of thrombosis. For example, having a hereditary genetic mutation that increases the risk of blood clots. Having cancer or an active malignancy is a risk factor for both venous and arterial blood clots. There are acquired conditions that can lead to thrombosis. So if you are an individual at a high risk of thrombosis, either because of family history or a genetic mutation you carry, or having a chronic condition or illness associated with thrombosis, I do want you to pay extra close attention to all of these preventative measures I've been talking about, but also the symptoms of blood clots. We want to be extra careful. If you are being planned for surgery, or you are hospitalized, or you're going on long flights or road trips, then I would want you to be extra careful, because your risk of developing a blood clot is much higher than the general population. Maybe not much higher, depending on what it is that we're dealing with. And please pay close attention to situations such as hormonal therapy, pregnancy, or the use of oral contraceptives. So now I'm going to move on to the topic of chronic illnesses, which I think is very important in regard to prevention of blood clots. Chronic illnesses are so common in today's world, and we know that conditions such as hypertension or high blood pressure, diabetes, hyperlipidemia, obesity are all risk factors for heart attacks and strokes or arterial thrombosis. And they're also risk factors for venous thromboembolism as well, primarily obesity in particular. And it's so important to have a primary care doctor or a regular physician or provider that you see at least once a year for annual checkup to be evaluated for these conditions and to make sure they're being treated. And this ensures that over the long term, you are avoiding long-term complications of these conditions, such as thrombosis, which is our focus of this episode and this podcast in general. And without further ado, I would like to welcome Dr. Shirisha Avadhanula. Shirisha is my very best friend in the world. I can go on forever and ever on how amazing and brilliant and incredible she is. Dr. Shirisha Avadhanula is a board-certified endocrinologist who's practiced at some of the most important and prestigious institutions in the U.S. And very importantly, she is an expert on metabolic disorders and metabolic dysfunction, which is very relevant in our discussion today, in particular for things such as obesity and diabetes. Thank you for joining me today.
I'm always happy to be here with you. Thanks for having me.
Yeah, I'm so glad we're doing this. This is our very first podcast together, you guys. And Shirisha and I have done so many projects in the past. Back in 2018, was it? We did health hacks.
It
That was a lot of
was.
fun.
Yeah, it was. It was so much fun, but I'm so glad we're getting back into it, and I
I
have to
know.
say I love the podcast. I am your number one fan. I
Oh
love
my
your
God.
podcast.
You are too kind, seeing that I've only done two episodes at this point. Um, and it's just so great because I there's no one else I'd rather do this with. So I'm just glad that we are. So Shisha, do you want to just tell the audience a little bit about what endocrinology is and what metabolic dysfunction is, or just what you want them to know about this field and your field of expertise?
Yeah, so I'm an endocrinologist. For an endocrinologist to be trained, we go through internal medicine residency, and then we finish our internal medicine residency, and we do a fellowship in endocrinology. Usually, it's about 2 years. You can also do a 3-year fellowship, which is what I did. I did an extra year of research. In endocrinology, we're going to see all sorts of hormonal and metabolic diseases. So usually, we're seeing people that have thyroid problems. Usually, we're treating things like diabetes, adrenal disorders, pituitary disorders, and there's a huge subset of patients that we also treat for medical weight management.
And by the way, for those who don't know, Shirisha and I did our residency together.
We did.
And then that was in Rochester, New York. And then we thankfully overlapped again in Cleveland during my fellowship and when you were already a faculty attending. And
That's right. Yeah.
so, one thing I wanted to ask you about is the prevalence of obesity. It is so common. I was looking up recent statistics, and back in like the 2010s in the US, the prevalence was maybe 30% or something, and the most recent number is like 40%. It's just getting worse. It's getting
It
more
is.
prevalent.
Okay, so the prevalence of obesity is high. I think we can all agree with that. But there was actually some recent data that was published by the CDC. And if you look at the last decade, the prevalence of obesity remains high. So it's
Mhm.
somewhere around 40% in the population.
That's a lot.
It's a lot. It remains high, but what we have to remember is there is actually no, sorry, my microphone went off. This is amateur hour. Sorry. So the prevalence of obesity, yes, it remains high, but I think the point that we need to actually pay attention to is the fact that severe obesity is on the rise. So obesity, yes, it remains high, but severe obesity remains on the high. And one of the most
And then what do
interesting
you mean by
things,
severe obesity? So
yeah,
BMI more than
so
40?
yeah, exactly. So it's a BMI of more than 40. Obesity is classified as a BMI of more than 30, right?
Hmm.
And severe obesity is classified as a BMI of more than 40. And BMI, body mass index, is a really great tool, right? It's a great tool that we use in everyday clinical practice. But remember, it has its setbacks, right? We have to take into account things like gender. We have to take into account things like ethnicity, things like body
Right.
fat distribution. It doesn't take into account visceral fat distribution, right?
Right.
Which is
It's
the
definitely
dangerous
like,
fat.
right. It's definitely not the
Exactly.
best measure of adiposity, right?
Right. It's not. It's not the best measure of adiposity, but it's the best measure that we currently have today that we use a tool as a tool in the clinic, right? So yes. So
And it's the easiest one.
and it's
Yeah.
the easiest one, you
Yeah.
just like don't waste your time, go on Google and go to the NIH calculator and use body mass index calculator, and you'll find out what your BMI is. If you're over 30, then yes, you are under a classification of obesity. If you're over 40, yes, it's a classification of severe obesity. And I think one of the most interesting thing that actually came out of that survey, that was just published back in September of 2024, was that more than double the amount of women had severe obesity as compared to men.
Wow.
Yeah,
Wow.
yeah,
Yeah, I mean, it's quite interesting to see these trends, and I don't know why that is. And to your point, that's right. Like maybe BMI isn't the best measure, but I think it's the easiest one when you're looking at large data. For example, like I every once in a while I'm curious to what my body fat percentage is, and there's like specific tools to measure that.
right.
Because like BMI, like you said, like for race and or I guess ethnicity and
Exactly.
sex, and those of us who have muscle mass, I'm flattering myself right now. So it's not the best measure. So the body fat percentage measurements may be more relevant. Why do you think it's on the
Exactly.
rise? What?
Okay, so there's a couple of things that I think we need to take into account, right?
Hmm.
So, I mean, the question I think is, why is severe obesity on the rise, and why is
Hmm.
it that there's no statistically significant difference with obesity when you look at the last 10 years data? And, I think the jury's still out on it, right? But I think that, we can all hypothesize. It could be the fact that in 2005, as we all know, we had the approval of GLP-1s, right? Which are really popular pharmacotherapy for weight loss now and really just exploded in popularity, I would say, over the last decade and particularly over the last 5 years or so. I mean, I read the statistic recently in 2022, in Q4 alone, 9 million prescriptions of
Wow.
GLP-1s were written, 9 million prescriptions. So, we're writing more prescriptions for GLP-1s and we're treating more patients. So, is that a potential factor of why the trends seem to remain high, but they're not, explosively going up? I don't know.
Right.
Maybe
Right.
are we capturing a population that may have,
Sure.
a BMI of 27 and over with one comorbidity, and are we capturing that population and treating them? Is that what's happening? But the
Yeah.
question is like, what's happening to the people in the middle, right? And you have
Right.
to remember that for those of us that sit in the office every day and write prescriptions for GLP-1s, these medications are profoundly expensive. They are at a very high cost for the patient. So, I have
So,
patients. Yeah,
yeah.
go ahead. Tell
No,
me.
no, sorry. Yeah. So, like, I was curious about that. Like, what's the patient population for whom insurance will pay for it, for whom it's covered? So, it is FDA approved for obesity. So, I guess my questions to you are, who is indicated? Not, I'm talking about the non-diabetic population. So, who would be indicated? What is there some sort of timeline where you say, okay, you got to try lifestyle modifications, diet, exercise for a certain amount of time before you become indicated for weight loss medications?
Well, yes. So there is, the indications for a GLP-1 strictly for weight loss. There are GLP-1s that are strictly approved for weight loss if you have a BMI of 30 or above. And remember, GLP-1s are also approved, and other pharmacotherapies for weight loss are also approved if you have a BMI of over 27 with one associated comorbidity. And that comorbidity can be diabetes, it can be high blood pressure. So it's approved for those reasons. And this is typically why we're giving it, in the clinic. Insurance approval, I would say it's hit or miss. Even with insurance approval, though, many of my patients tell me that the medication is really difficult to afford. Somewhere around 50% of patients on GLP-1s say that their medications are difficult to afford. So, to kind of go back to the point that we were talking about
Sorry,
earlier.
I'm just in the microphone. Yeah, go ahead. Yeah.
Yeah, why, kind of like talking about to the point that we were talking about earlier, why is severe obesity on the rise? Okay, so are we treating, our patient population who is obese, and are they losing affordability to this medication? And we are kind of losing this subset of population that kind of transfers over into this severe obese category. And it's sort of this tale as old as time, right? Are we losing the people that would benefit from these medications the most, that have the least accessibility to them? Is that what's happening? I mean, I don't know.
Right.
But I can certainly hypothesize, based on the numbers and kind of based on my experience. I think it's a contributing factor. I don't think it's the only thing, but I certainly think it's a contributing factor. And remember, obesity rates remain high because of reasons that they've always remained high. Multitude of factors, things like we're more sedentary than normal, right? We sit in front of a computer. I mean, I can speak for myself, and probably you too. Like on a day-to-day basis, we spend more time in front of a computer
Not
than
me.
ever before.
Just kidding.
Definitely me. I will say I spend more time in front of my EMR than ever before. And I can certainly speak to my
Yeah.
colleagues. We are more sedentary than ever. We have less food choices than ever. We have more and more people that are living in food deserts that just don't have accessibility to healthy food. So it's really a combination of factors of why the prevalence remains high. But I think it's a really interesting conversation of why severe obesity is on the rise.
Definitely. And you mentioned diet because that's, to me, like the most important determinant, um, or at least the most useful way for weight loss is really diet, more so than exercise. Of course, exercise is necessary and it's important and it helps with the metabolism and heart rate and so on.
It does,
But
yeah.
in terms of like the amount of calories being burnt, if you jog for, I don't know, half an hour or 20 minutes, you're burning about 300, 400 calories, which is barely half a slice of a cheesecake. So it's so much easier to
Are you
eat
eating
better.
cheesecakes at night? Is there something that we need to talk about? Are you eating cheesecake alone at night?
I love cheesecake, but I'm very, careful with my calories because if I cheat one day and I'll have a slice of pizza, next thing I know, it's in my love handles. So it's got to be quite careful with what I'm eating. But I do allow myself one cheat day a week. And so the what I was kind of going about is the if we watch what we eat, it's such an effective way to lose weight just by calorie counting. There's like calorie counting apps where you get to register whatever you ate that day. And then when after writing it down, you realize, whoa, did I really just consume 3,000 calories today and 150 grams of carbs? So tracking it makes you realize that there's so many ways to improve on our diet. And
Yeah.
this is something that I think everybody needs to pay attention to. And you know, it's harder, right, for people. Like some people don't know how to like start eating healthy. Do they need
No,
to,
it's
you know?
true. It's definitely, there's a reason why the field of obesity and the field of weight management is so complex, right? There's no one-step solution. There's no one answer. And I'm definitely not as careful as you. I go in the kitchen and I eat whatever I want. But truthfully, the process of weight loss, it really does start in the kitchen, right? And I think having a food log, which is what we always recommend, it
Mhm.
not only allows you to look back and track and actually see the amount of calories that you're consuming, but it also forces you to really eat with intention, right? So every single
Right,
thing you put in your mouth, you have to write down. So it
right.
really forces you to kind of eat with intention. Um,
Exactly.
you know, of
Exactly.
course, like that being said, yes, we have our patients on a food log and we tell our patients, certainly lifestyle modifications, try your best to exercise, 3 to 5 times a week for 30 minutes. And I'm talking exercise. Like if you're not working hard, you're not working out. If you're not out of breath, you're not working out. So I'm
Right.
not saying like going for like a nice walk. I'm saying really getting on the treadmill or, getting in the swimming pool and really being short of breath. So remember, like if you're not working hard, you're not working out, right?
Definitely.
So remember, the exercise component of that. But it's not, I don't want to oversimplify this because it's really not a one-step solution, right? It's not just diet and exercise and then that will solve all your problems because that's really not true, right?
But for the majority, oops, sorry, I
Oh,
just kind of kicked my microphone here. Can you still hear me?
yeah, I can hear you.
Sorry. But I feel like for the majority, it's true. Like for most people, it's just looking at the trends. There hasn't been like a change in our, evolutionary genetics or so on over the past 2 decades. We as a society were much healthier before. Like 2, 3 decades ago, the rates of obesity were much lower. So something changed. I don't know what it is, whether, like you said, it's sedentary habits or paying less attention to our diet and so on. And
Sorry, can we
yeah,
can we pause here for just a second?
yeah, yeah, yeah.
Okay, hold on.
This is the fact check part of the episode.
Okay, you said decades, right? Okay, fine. I agree with you on decades. But in the
Okay.
last like century, we have changed. But okay, yes, I agree with you on
All right.
decades.
I just won this argument just for the
Okay, fine.
record.
Let's just
Let the record
fine.
show.
Let the record show.
Um, so what was I saying? Yeah, so I feel like because I'm a believer in trying to find the simplest solutions
Yeah.
and the simplest explanations for things, and then going into the more complex nature of metabolism and so on. And so that's why I think sometimes something as simple as just reading the label on things that we're consuming and keeping track of the calories and carbs and the macros and so on. And that's why I also like I meal prep. well, shameless plug-in, I have my own meal prep business, which is something I'm really passionate about because it's worked for me. That's all I've been eating my whole adult life.
Are you allowed to do
And
that?
I wanted to kind of bring that to people. So it's called Kinetic with a K at the end. This is my podcast. I get to plug in my own business. All right. um, so so on that point, I feel like the majority of people would benefit from lifestyle changes, diet, exercise, eating healthy, and so on. But you're right, it becomes more complicated with things such as the syndromic nature of metabolic dysfunction. And actually, I do want to, I want you to tell me more about what metabolic dysfunction is. How would you explain it?
Yeah, I mean, at its simplest and at its core, really, metabolism is just how we convert food into energy, into storage. So it's a complex series, basically, of chemical reactions that happen in your body of how we convert food into energy and into storage, right? And if you have a metabolic dysfunction, excuse me, you're disrupting that process. Right. And so I think the most common example of this is diabetes, right? I mean,
Right,
what's the most common um, what's the common factor in type 2 diabetes is a metabolic dysfunction. It's insulin
right,
resistance, right?
right,
So when you have a normal, say, a normal physiology, I would say what insulin does, it basically acts as a key to glucose to enter your cells. And then through, a complex series of chemical reactions, we get energy from that glucose, right? And then what happens when you have insulin resistance, your cells become less and less receptive to the effects of insulin. So glucose
right,
never goes inside the cell, never gets
right,
converted into the energy that we want, right? And then it just hangs out in the blood. And then what ends up happening? You end up being in this chronic inflammatory state, right?
right.
And then, glucose is toxic to myelin, to nerves. And so you have all of these series of essentially bad things that can happen because of that glucose buildup and that kind of
Exactly,
chronic inflammatory state.
exactly.
That's what a
And that's
metabolic
how in part
dysfunction is. Yeah.
Exactly. And that's how, in part, this leads to thrombosis because having chronic inflammation and activation of our inflammatory pathways does trigger our procoagulant pathways as well. So, this does directly or indirectly lead to hypercoagulability. And in the previous episode, I discussed Virchow's triad, which hypercoagulability is one of them, as well as venous stasis. So, with obesity, that there is probably venous stasis to some extent, as well as having a sedentary lifestyle and so on. So these things do contribute to thrombosis long term. So that's why
Does
it's so,
it does it
yeah.
cause is the free radical damage in diabetes, is that also a cause of thrombosis or no?
It's I think hypothetically speaking, it could be because you could argue that this may lead to endothelial dysfunction. Anything that leads
Mm,
to either inflammation or injury of the endothelium could be a cause for thrombosis. And statistically speaking, so like those who have obesity, meaning a BMI more than 30, are at least 2 to 3 times more likely to develop a venous thromboembolism than the
wow.
general population.
Yeah.
And venous thromboembolism meaning either a DVT, a deep vein thrombosis, or a pulmonary embolism. And there was another study that looked at the, I guess, quote, dose dependent. So with every 5 point BMI rise, the increased risk of venous thromboembolism increased by 20 to 30% or so. So which makes sense, it's a
Yeah.
gradient type of
The
thing.
kind of a
So
cumulative effect. Yeah, that makes
yeah.
sense. Yeah.
So it's so important to address obesity and chronic illnesses that could lead to venous thromboembolism as a way to prevent thrombosis.
I think you and I were just talking very earlier in the episode. These chronic diseases are really prevalent, right?
They really are.
Was it 46% for hypertension? Remind me.
Yeah, something like that. 47% hypertension, 40%
Yeah,
obesity.
for
And these are the
obesity.
United States numbers. I don't know what it is globally, to be honest. And like 10 to 15% diabetes. So
Yeah,
it's
38
becoming so
million,
prevalent. Yeah.
38 million people in the US with diabetes. And primarily, it's those with type 2 diabetes. So
Right.
certainly, reversible things. When it comes to hypertension, we talk about primary hypertension, we talk about secondary hypertension. Primary hypertension is just when we don't have a cause, when we don't know what's
Exactly.
causing the hypertension, right? And then, we give you a medication and, we ask you to be compliant on the medication. And we also ask you to mitigate other risk factors that may cause you to have bad adverse outcomes in addition to hypertension. So if you fall into the obesity category, we also ask you to lose weight, right? And so when someone has secondary hypertension, for example, it's really, really, really important. And I like that you said in the beginning of the episode, go see your primary care doctor, right?
Yeah.
Because it's really important if someone has a secondary cause of hypertension, which basically just means there's something underlying that's causing the hypertension that is potentially treatable. One of the most common causes is obstructive sleep apnea. We see this every
Right.
single day. We
Right.
have patients with obstructive sleep apnea and then they develop high blood pressure. But by treating the obstructive sleep apnea, you can really significantly reduce the blood pressure and potentially even, reduce the risk of these people going on medications, right?
Right.
So I think,
Right.
reducing your risk of either developing the chronic disease or making the chronic disease worse is going to reduce your risk of thrombosis. Is that accurate? Tell me.
Absolutely. If it's simple as that. So if there is a risk factor that's ongoing, that is a known risk factor for thrombosis, then eliminating that risk factor will, as a result of that, lower your risk of thrombosis. And in fact, this is something that comes up often when we make decisions about the duration of anticoagulation for those who are on for those who've had a blood clot and so on. So it's really a culmination of risk factors. And the less risk factors you have, the less worried we are about a recurrent venous thromboembolism. So you're absolutely right about that.
Yeah. And I think when we talk about obesity, we have a lot of great pharmacotherapy. We touched on GLP-1s, previously, and they're only getting better and better, by the way. In
Good.
in our data, semaglutide, which I know you've heard about,
Right.
somewhere around 14% of body weight reduction, which is really good.
Wow.
And then we graduated to tirzepatide, which was something along the lines of 20.9% body weight reduction. And then we have this new kid on the block, retatrutide, which is supposed to, I think, have FDA approval by 2025 in Q4.
What's coming up?
So
Could
it's
we do
coming
an
up.
episode, a specific episode about all the weight loss drugs, talking about risks,
Absolutely.
side effects, and what kind of impact they've had, and also like the role of pharmaceuticals in terms
Absolutely.
of yeah,
That's a huge topic. That's like
right,
10 episodes. That's like 10
right,
episodes. But yeah,
absolutely, right,
I mean,
yeah.
we should
Let's do that.
absolutely. No, no,
Yeah.
definitely. So, we have good pharmacotherapy, with our GLP-1s. Like I said, retatrutide is coming up with something like 24% body weight reduction in just 40 weeks. That's a lot, right?
Right.
So, we do have these pharmacotherapies for weight loss. If GLP-1s are not appropriate, we have other pharmacotherapy treatments.
Hmm.
But I like what you said earlier. We do want our patients to try to succeed without medications. Of course, that's the first step. We always
Exactly.
offer lifestyle intervention. I love what you said earlier. It's true, right?
And I
We
think
always,
that's like the take home that I
yeah,
want them to I don't want to make it sound like we're necessarily advertising a drug or
no,
promoting
absolutely
something.
not.
Neither of us
I
has a
don't, I
yeah,
have no
and
disclosures.
neither do
Yes,
I. So neither of us have conflicts of interest with the manufacturers of these drugs. I just want to point that out. We're just kind of sharing some of the data that they are effective. There are certain side effects that we need to worry about. But more importantly, is if there's a way to do it naturally, then that's preferred. So
I love
we
that.
really want to focus a lot on how you can prevent not just thrombosis, but the things that could lead to it, such as obesity, in by doing just by everyday measures, just eating healthy, um, calorie counting, monitoring your macros, and things such as like the Mediterranean diet, which is quite has been shown, in different data to lower your risk of
It's a great cardiac
cardiovascular
diet.
disease and so
Absolutely.
on, in addition to exercise. So I just want to stress the importance of that as a preventative measure for a
No,
lot of things, not just thrombosis.
I definitely
Yeah.
agree with you. And, my patients consistently ask me, probably the most common question I get is, what is the best diet to lose weight? That's the most common question I get.
Right.
And the truth is, the best diet is the diet that works for you because
I
a
love that.
diet, it's right. It's the diet
I
that
love
works
that.
for you, right? So it's not really about you going on this lifestyle change or this diet or however you want to call it and then losing the weight and then potentially going back to maybe old habits and then gaining back the weight and then going in this yo-yo pattern. The
Absolutely.
key is consistency, right? We always, always, always have to be consistency because it takes 3 to 5 years to change your metabolic set point. 3 to 5 years, that's a long time. So I always tell my patients
Right.
the best diet is the diet that you can stick to for 3 to 5
Absolutely.
years consistently. So if that's intermittent fasting and
That
you
is
can do
so
that for three to
important.
five years, you got to do that, right?
I think
So
this is like I think you definitely like hit the nail there. So the most important thing is the diet that works for you and the diet that you can stick to.
exactly.
And these 2 points are so important because certain diets don't work for everybody. And whether it's, how much carbs you're consuming, protein,
Yeah.
the balance, and also the timing of macros makes a difference. It did for me personally. And also something you can stick to. If you can't stick to it, then it's not the right diet for you.
It's
If you,
not. I mean, I
yeah,
tried intermittent fasting. I did it for maybe a
yeah,
month and then I couldn't do it. It just didn't fit with my lifestyle. I
exactly.
wanted to sit down and I wanted to eat with my son. I wanted to eat with my family. I couldn't do that, right? I couldn't make those adjustments. And if that doesn't work for you, then that's okay. Try something else. But the point is don't lose faith and be consistent with it. Whatever you do, it's great
Absolutely.
if you've lost weight within, the first 3, even 6 months. But the purpose of this is not for us to kind of, backstep. I think it's called backstepping, right? I forgot the term. I think it's
Um,
backstepping. I mean, or don't backpedal or whatever it is, and kind of go back to old habits
yeah, like
and then
relapsing. Yeah.
and relapsing.
Yeah.
Yeah, and
Yeah.
then maybe gain the weight back because it
Exactly.
really it doesn't help us for our future weight
100%.
loss efforts. So
100%.
I would say
Well,
just, yeah, give yourself grace and be consistent.
well, Shirisha, I want to thank you for your insights, your expertise, and your words of wisdom today. It's been great to have you, and I would love for you to be a regular on Clotcast. There's so many things to discuss,
I'm available. Call me
obesity.
back.
Yeah, I'm glad. There's so many things. There's artificial sweeteners I want to talk about, erythrocytosis, testosterone, estrogen, a lot of things that we would
Yeah.
have great conversations about. So again, thanks so much for joining today. I had a blast.
Me too. I had so much fun doing this. I'm so looking forward to the next one. And yeah, let's do it. Call me back anytime.
Absolutely. Well, ladies and gentlemen, this wraps up our episode today. So, to recap, the ways to prevent blood clots, there's things that apply to the general population that we went over. So, very easy measures, such as trying to eat healthy, trying to maintain a healthy weight, and regular exercise. And then certain provoking factors or situations, such as surgery, hospitalization is a very frequent cause, as well as immobility due to either a sedentary lifestyle, long distance travel by plane or land. And lastly, knowing your risk factors. It's important to know your risk factors, whether it's a chronic illness that you have, such as obesity. We didn't talk too much about PCOS today, but that's another one. Hyperlipidemia, diabetes, and so on, as well as genetic risk factors, such as carrying a mutation that increases the risk of thrombosis, which goes hand in hand with knowing your family history. I hope you found this episode helpful and thank you all for tuning in. Please let me know what kind of questions or topics you'd like me or my colleagues, such as Dr. Avadhanula, to discuss in the future. Let me know in the comment section below. Thanks for listening.